All of our members here, first of all, how much I appreciate, again, how much I appreciate, this is, my friends, this may well be the most important bill we pass this legislative session. It's important. And so things that are important take time, because if we rush, we make mistakes. And that's not going to happen on my watch. And we're going to do it right. And so there is a substitute bill that is unlike what you heard. There are certainly parallels, but and the framework is the same, but the chairman will explain changes he has made in perfecting this bill. And so what we're going to do today, we're going to hear the committee substitute to House Bill 290 by Chairman Ed Setzler. You have that, dear. Chairman, let me turn on your mic, and you are on. I do want to ask everyone, I'm sorry. Yeah, thank you. I do want to ask everyone here if you have to please wear masks, and we we're being everyone needs to follow all of our guidelines for COVID, and please do so. And Mr. Chairman, the floor is yours. Oh, I'm sorry.
Thank you, Mr. Chairman, members of the committee. Pleasure to come back before you today. And I really appreciate the engagement of this committee, Mr. Chairman, last week. As some who are here or watching may or may not know, we had a presentation of a different LC version last Wednesday before your committee and got some very important feedback. We had made a number of revisions before we presented that and have made a number of revisions since then based on feedback from the hospital long-term care community, from legal representatives, representatives of the legal profession. And if it pleases the chair, I'd like to sort of give an overview very briefly, but really spend a lot of our time walking through the details of the bill. That was your direction to me, Mr. Chairman, for us to kick off. So HB 290, the LC version you should be looking at today should be LC 338655S. And that is was developed with input as recently as yesterday evening. And again, our goal is to listen to all the input that makes the bill better and that fits with finesse in the many circumstances and settings that this needs to be fit into and work within, but addresses this underlying issue of rights of patients to have assistant, have a representative with them in an acute care setting to make decisions for them or help them make decisions. And in a long-term care setting, have representatives who can help them make decisions, but also facilitate visits by close family members in a way that those family members and representative visitors are following all the procedures of safety that's required. Mr. Chairman, as we talked about before, this is not a coronavirus bill. It's not written around COVID-19 for the spring of 2021. It's written in anticipation of any number of future conditions similar to or very different from COVID-19, which emergency powers could have an impact on access to representation and visitation in our hospitals and long-term care facilities. So it's not just focused on coronavirus. I want to be very clear about that. In fact, this goes into effect beginning in July of this year so that the department can write rules around it and make sure that any clarifications that need to be made or that are appropriate at their level can be further fleshed out within the confines of this bill. But this bill is intended for emergency circumstances moving forward. So that being said, the issue that it's seeking to address is to provide assurances where appropriate that representation for patients is not denied inadvertently by policies, and that visitation where that's appropriate can also be available to people in long-term care settings. Mr. Chairman, what we've done here that is a fundamental change, I'll start, and it's evident on page 2, which is really the first page of the bill, is we have separated out the concept of essential caregiver and representative. Now, we've done that because 42 CFR, the CMS regulations talk about the representative as having a special legal status. So if I've heard anything in the last week, I've heard, oh, there's lots of CMS and lots of federal things you have to be conscious of. Oh, you don't want to mess this up. It's very complicated. Well, we've delved into the depths of that. And what this substitute does is it takes the very language of CMS regulations, 42 CFR 483.10, which deals with long-term care facilities, and 42 CFR, 482.13, dealing with hospitals, and takes that language and, as directed and as contemplated under CMS, puts the status of representative and essential caregiver in state law. This handout that I've passed around, I'll start with that before we jump into the bill, Mr. Chairman. But when you look at the this 42 CFR 482 handout, condition of participation, patients' rights in hospitals, and I'm going to share this, Mr. Chairman, for context. As you can see, notice of rights and then exercise of rights, it talks about the patient's representative as allowed by state law, as allowed under state law. Again and again and again, the status of the representative, the person that makes decisions for patients, is there's a minimum standard that's fleshed out by CMS, but it is otherwise governed by state law. Okay, so I want to be very clear about that. And because of that, it's our job, where medical practice is regulated and where civil practice is regulated, to flesh out those responsibilities, the contours, if you will, about what the representative who represents a patient's interests, helps them make decisions, has rights as clearly defined under federal regulation to participate in the planning and the oversight and execution of care. That's clearly prescribed in 42 CFR, which is our federal regulations. Okay, that which has the effective binding law. Okay, so what you see today is that if there's anything that's significant about the substitute you're looking at, it was written, and there'll be parts of this that are literally direct lifts out of federal regulations that affect these circumstances, and we're answering the question that's contemplated in federal regulation is as allowed under state law. So we're defining as a state those things that the federal regulations say is the state's province to define. Just want to say that as to kind of frame this whole discussion. Okay, so we're not operating blind to, ignorant of, or in opposition to the federal regulations, which flesh out state law. We're operating in concert with them. And if there's any conflicts that people could highlight that have the effect of law, that's the process we're looking to perfect and work through. But I wanted you to see that today, both in the hospital setting and in 42 CFR 483.10, the long-term care setting. It applies in both. And I've highlighted some things that I think are relevant to you. If you can look at those, it sort of sets the stage and gives you sort of the trail of breadcrumbs of where we've come since last Wednesday's meeting. With that said, Mr. Chairman, if it pleases the chair, I'd like to walk through the bill, highlight the differences, and at any point, if you want me to take questions as we go or wait to the end, it's completely up to the chair how you would handle that, Mr. Chairman.
Mr. Chairman, begin with review the bill thoroughly as you did last week, and then we want to have members offer any questions as much as possible. Thank you.
Again, we talked about this fundamental shift from how we treated this idea of essential caregiver since last Wednesday. Last Wednesday, the idea of representatives that helped assist in healthcare decisions and that were visitors that provided moral support to patients, that was all in one category last time. And we called them essential caregivers. But what we recognized as we took questions and delved into this deeply, there's two different functions that we were incorrectly conflating into one. So we've separated those. We've got what we call essential caregiver, and we have representative. Okay, a fundamental change from what we had before. Okay, if you look on lines 31 through 35 of the bill, I'll go out of order, but for purposes of emphasis, representative is an individual 21 years of age or older designated by a patient or resident, patient in a hospital setting, resident in a long-term care setting, to assist in exercising such patients' rights And we use the word right, it's not a loose term. It is a right in the sense of a right. It's a fundamental right. They have a right to be represented, whether they're incapacitated, where they're on a pain-killing drip that maybe they're a little bit loopy and not quite themselves, but are sort of halfway there, or whether they're fully lucid and are seeking to make decisions. They have a right to a representative, their next of kin, as we would typically think of it, to be present, to participate in that. And as we can see, this right to make, and what you're going to see on lines 33 through 35 are lifted word for word, letter for letter out of 42 CFR 42 and 13 and 4310. Right to make informed decisions regarding care, being informed. Be informed of their healthcare status, to have an understanding of what the real status is of this person. Now, if you hold an iPhone up to somebody who's in the hospital and you can see some of them, are you able to make the kind of decision that you can if you're bedside? The answer is no. So the idea of being informed of their health status, be involved in care planning and treatment. So the planning, what's coming up next? What if this doesn't happen? What are the two options then? And then as a result of that, the treatment, be involved in treatment. This is straight out of federal regulations, right? Request or refuse treatment, to understand what they're going to do and what they may not do. Say, we don't want that, we want this. There's a member of our body who was involved in a phone call just inadvertently with one of their family members in a hospital within the last year, that but for having been on that phone call, our colleague contends their sister would have died because of the treatment that was being given by a less qualified non-specialist for their unique condition. The idea of being involved in that decision-making is a life-changing impact for many people. And that's something that this representative is there to do. And there's only one of them. Access medical and personal information, manage finances. And again, if the person's incapacitated or not able to act on their own behalf, act on behalf of such patient or resident. So again, Mr. Chairman, at the risk of beating the dead horse, this representative is a new thing that did not exist in the bill before because we missed it. It's written all throughout federal regulations, and federal regulations talk about that representative and gives them the special status of having the right to make these decisions, whether the person's incapacitated or whether they're fully capacitated, but it's the other person with whom they make wise decisions aren't left to make those decisions alone. Mr. Chairman, 23 through 27, the term essential caregiver, which was broader before, has been narrowed to mean an individual 18 years of old or older, who's either a family member. If they're a family member, they qualify, or if they have an ongoing relationship, if they're regularly engaged with a resident to provide companionship prior to their entering the facility. That's what qualifies you as an essential caregiver. Okay. So it's, again, that's focused more on companionship. They understand people and they assist in their well-being, but they're not the decision makers. Long-term care facility, Mr. Chairman, hasn't changed. Again, that continues to be a skilled nursing home, intermediate care home, personal care home, community living arrangements, assisted living, or hospice facility. So there's the definition of what long-term care has not changed any in the bill. So that's as we sort of get into the essence of this bill, what we've done, and you'll see on lines 36 through really the bottom of page 3. This is where we create separation between the patient's ability to have access to a representative, subsection B, and essential caregiver, subsection C. Okay. So subsection B, beginning on line 36, is this representative who is a decision maker. The patient's right to have access to this person's defined beginning on page 36. The caregivers, the other people that want to show up and visit and that are important, but not essential as decision makers, will happen down below on page 3. Again, beginning on or after July 1st, the hospital or long-term care facility shall not institute any policy that limits access to in-person physical contact. I'm on line 38 through 39. In-person physical contact. Not through Zoom, not through iPhone, present physically is the standard that we're insisting that the hospital and long-term care facility would provide. Now, what we've changed here, and this is a big change, Mr. Chairman, there was concern about how many of those representatives, how many decision makers would have access and how often they would have access and what their duration was. What we've changed, Mr. Chairman, on lines 40 through 41 is that the duration which they'd be given access in a hospital setting would be a minimum of 1 hour per day. Now, there are people who've come to me, I've been lobbied over the last week, they've come to me just insistent, said, Chairman Sesser, we've got to have 24/7 access. Got to have it. They've insisted in this. And I understand that there's a strong argument for that. But what we're doing here is we're prescribing a minimum. We're prescribing what shall happen. And what we've got in the substitute is a minimum of 1 hour access per day to this one legal representative. Now, we talk about skinnying down this bill. We're skinnying down this right to visit in this substitute to 1 hour per day minimum in a hospital or a long-term care setting. So you think about acute care, you think about all the circumstances that could arise. People would say, well, gosh, Representative Sesser, this is just not enough time. I need more than an hour. But this is a mandate, right? This is, again, in furtherance of the decision-making authority and assistance to this patient that's given to us by federal law and regulation. We're saying we're fleshing out our duty. Hey, what powers does the representative have? It's 1 hour a day, and it's for any stay that's longer than 12 hours. Now, does that mean the person can't come in 3 hours after the person's admitted to the hospital? They absolutely can. And I think they will be. I think hospitals, even in difficult circumstances, will allow folks in perhaps sooner than that as they can. But the mandate we're providing here, what we're mandating is that if someone's in a hospital setting or long-term care setting, they're a legal representative who makes decisions for them and or with them. If the stay is going to be longer than 12 hours, you have to give them physical access. If they come rolling in an ambulance, the gurney takes them in, they're being assessed, they're being triaged, they're being worked on. There's great value in having the representative there, but we're not even requiring that in this bill. It's only stays beyond 12 hours in a hospital setting. This representative would, by law, the hospitals by law would be required to give 1 hour per day, 1 hour per 24 hours of physical access. Because in the hospital setting, it's less about accompaniment and morale. It's about decision-making and making life-saving decisions based on someone's history, okay? So, Mr. Chairman, I wanted to draw that distinction very clearly. We also draw out, and I want to say on line 42, this is a change from the previous substitute. You think about this critical decision-making authority that's part and parcel to the delivery of care. This isn't letting visitors in. This is the decision maker who's making decisions for the person or with the person. Does the need for having that disappear under emergency circumstances? Even under the most severe emergency conditions in a hospital, the ability to make decisions for patients and with patients exists whether there's an emergency declaration or not. So what we have here on line 42 is notwithstanding code section 35-351. What that means is even during emergency declarations, even during states of emergency where there's broad shutdown of hospitals and facilities, a patient has a right outlined in federal law and regulation and clarified and completed here. They have a right to access one person, the decision maker, 1 hour a day in a hospital setting, even during states of emergency. That's something the governor, through their emergency powers, can't waive because there's still a need for the decision-making authority of that representative. That's a change from the bill as we presented it before, okay? Because it's one person, and it's 1 hour, and it's critical decision-making. It's not just visits, okay, Mr. Chairman? We also talk about, again, we use the language lifted straight out of the federal language, inform their health status, involved in the care planning, request for refused treatment. All that's lifted straight out of our federal language. We talk about access to in-person physical contact. And on lines 49 through 51, we clarified furthermore, such access to in-person physical contact with a designated decision-making representative is deemed equally essential in the provision of care as other people in the care setting. You think about the people from the person that's changing bedpans to rolling in your lunch and cleaning your bathroom and helping people change clothes, nurses, doctors. That whole process of care requires a decision maker. And the decision makers, this legal representative, is essential to the delivery of care as the technician, the nurse, the doctor. They're integral to the process. They're not just a visitor that wants to come in. They're integral to the delivery of care. And we make it very clear on lines 49 through 51. That's the case under Georgia law. We give them that status because they're the decision maker representative. Okay. We do say on lines 52 through 53, hospitals should not be prevented from imposing reasonable safety requirements relating to in-person physical contact of representatives. So the hospital gets to determine time, manner, place. They can say you can come in from 1 a.m. to 2 a.m. You have to wear a mask. You have to have a negative PCR test. In this ward, you might have to have a face covering. You might have to have full scrubs. All of those reasonable requirements are completely decided by the hospital. We give them that complete power under state law. But once those conditions are satisfied, that's the circumstances in which this legal representative has access to physical contact with the patient. That's the representative framework here, Mr. Chairman. I will tell you down below, I'm jumping ahead a little bit, but down below, if you guys can turn down to page 4, subsection D, lines 67 through 74, there's an exception to this. Nothing in this exception shall be construed to establish the representative as an agent or employee. They're not an employee of the hospital. But it says beginning on line 61, the hospital may temporarily suspend or terminate access even to this essential representative. Certainly caregivers in another setting, but even the representative can lose access temporarily or permanently for failure to comply with reasonable safety requirements. If the person repeatedly takes off their mask, they can be suspended in their ability to be there, even though they're the legal representative, because they're not following the rules. Furthermore, and this was added recently as well at the request of the Hospital Association, by demonstrating court of competent jurisdiction, if you can demonstrate probable cause, a pretty low standard that this representative or caregiver is involved in a criminal activity, you can get them out of that setting. If you think that, for example, this so-called representative is a sex trafficker or a pimp or an abuser, and they're there trying to represent this patient or operating outside their best interest, the hospital sees that, they report that. If you establish probable cause, they can be removed. Those of you who spend time around criminal law, probable cause is a pretty low standard. It's the standard for an arrest. If you have enough cause to be able to arrest somebody, you have enough cause to be able to kick them out of this hospital setting and get rid of them, okay? It's not preponderance of the evidence. It's not beyond a reasonable. It's not a conviction. It's if there's probable cause, if there's enough cause, they're involved in a crime to arrest them. It clarifies that they can be removed. They don't have this right. Okay. Mr. Chairman, I appreciate your deliberate walk through this. That finalizes sort of the powers of this legal representative, which we didn't have in the bill we presented last Wednesday. Beginning on line 54 of the bill, we get back to the concept of essential caregiver. And under this bill, we've made a big change. Under this bill, we've made a change that many will be mad at me for making that want to provide more access than this bill provides. Under the substitute provided before you, this essential caregiver, this family member that provides care and support and morale support, doesn't by right have access to a hospital. Only this legal representative, this one legal representative by this bill has right to the hospital because they're decision makers. Decisions are made in acute care settings and hospitals. Okay. But in the long-term care setting, from a nursing home all the way down to a community living arrangement, that whole continuum we talked about, these essential caregivers do have access. And in those settings, if they follow the rules, for anyone who's staying longer than 24 hours, and in most long-term care settings, you're staying dramatically longer than 24 hours. But if you're staying overnight, these essential caregivers, if they follow the rules, have access to 2 hours a day of visitation. because that setting is different than the acute care setting. It's not about decision-making as much as it's about morale and support and supporting the person in that living arrangement setting. There will be people who are mad at me for saying, well, gosh, Representative Setzer, why can't caregivers come into the hospital too? In many cases, hospitals, I'm hopeful, will allow them. But in terms of what we mandate in state law, the decision-making function of the representative is what's essential in the acute care hospital setting. We believe that the representatives having access to long-term care settings and essential caregivers having access to long-term care settings is really the spirit of what's needed as we've unpacked the last 12 months and what, more importantly, the future might hold under any number of emergencies. One thing that's important to note, Mr. Chairman, as we look at subsection C beginning on line 54, access of these essential caregivers is going to be subject to the emergency powers of the governor. So the governor can still establish the tiering and what counties they can, what counties they can't. All that's still going to be within the province of the governor, because these are caregivers. They're supporting people in their arrangements, but they're not part and parcel to decision making and care. So it's still going to be subject to the governor's emergency powers. Once again, we talk about the reasonable guidelines, the long-term care facilities, and we have the power to establish reasonable guidelines to maintain safety. And again, these caregivers also are subject to this provision of, if you fail to comply with the reasonable standards, you can be temporarily suspended or permanently removed for not following the rules. And then lastly, again, this criminal provision, if you're involved in a criminal activity that poses a threat to anybody in the hospital setting, not just the patient, but anyone, you can be removed temporarily or indefinitely. We clarify, Mr. Chairman, this is an addition in lines 75 through 77. Folks have asked, what's your remedy here? What if the facility, hospital or long-term care facility blows you off and doesn't give you your rights? We just clarify that a patient, representative, or essential caregiver may bring a civil action in court for failure to comply with the provisions of this code. We don't see that as creating a highly litigious environment. It's just simply a court can look at the nature of this. This right exists today under law. I don't think we even necessarily need it in the bill. But we do clarify that you do have a right to civil action to enforce this. If the hospital or long-term care facility is just blowing you off in obvious contradiction of these rules, you can go to court and make your case. And then lastly, Mr. Chairman, the bill wraps up on lines 78 through 85. A dramatically different legal threshold than what we had before. Before, we sort of filed the bill around a much broader immunity. What this gets us to is, and we've gone through changes over the last several days, so folks from the legal profession that's seen some different language. This takes us back to the coronavirus standard of willful or wanton negligence, reckless infliction of harm. Hospital would only be held responsible civilly if there's gross negligence, willful or wanton misconduct that leads to the injury or death arising from compliance with this. So if someone comes in, they bring some kind of sickness in, it leads to injury or death, the hospital could be held responsible, but it's a gross negligence standard. It's very similar to this coronavirus negligence framework we've created in this very narrow sense. We've narrowed this down the last couple of days, and that's, Mr. Chairman, what we have in the bill. So I know it's not a very entertaining walk through a bill, but I think it's an important subject, and Mr. Chairman, I'd be glad to take questions.
Okay. We'll now take questions from the committee. Number 4, is that Representative Robichaud? I can't tell these numbers here anymore, the way they're changed.
Yes.
All right, Representative Robichaud with a question.
Thank you. And thank you, Chairman Setzler. And I think we've all said, we want to work this out, but I do have some questions from my background and yours. Under the conditions of participation with, for CMS that you quoted, what I also noted, though, that Part H, which documents that it says that the hospital has to have a written policy and create those limitations. And then when you go into the interpretive guideline in that, it says one of the things hospitals, and I'm more familiar with hospitals, I apologize, than nursing homes
sure.
and long-term care. but in a hospital setting, that they can use reasonable clinical information based on their best medical decisions about their policies. They have to be written, they have to be explained to the patient.
Mhm.
One of the first things that's mentioned there is that they need to consider infection control
Mhm.
issues.
Mhm.
I think all of us would agree COVID was an infection control issue, and still is.
Yes, ma'am, indeed.
So when we say we're overriding that, and I think that's part of the concern, when that's a reasonable, I'm not trying to understand, having been in healthcare for many years also, oftentimes some of these decisions unfortunately do have to be made by phone calls. I worked in stroke. So oftentimes we didn't have a family member come in with a patient who had a stroke. So that patient is not able to give consent, not able to for treatment. There were phone calls that were done because it's an emergent situation.
Sure.
So I'm trying to see why that would be so different. And my concern is that if I, as a family member, don't agree with that medical advice, and I'm not going to say it's always right, but that I get to sue them in a civil court now,
Yeah.
I have a problem with that.
Let me address that just quick. This doesn't change that setting. This doesn't change the medical malpractice statute in any way. All this provision says is, if for purposes of access, for example, if they don't give you access in accordance with this code section, that's the only basis we're
Correct,
clarifying.
but to me, this is overriding that provision of CMS Part H that says that one of the things that a healthcare facility needs to consider when they put their visitation policies in place does have to do with infection control, can be infection control. It can also be about the safety of other patients. It can be about situations that, we talked, I think the last time, in emergency rooms. I think those of us who have been in emergency rooms lately, especially when it's been overrun with patients, those patients that are out in the hallway, that they're in what's called hall beds. And,
Sure.
I think to have people sitting there while we're also trying to deliver that kind of care, to me, it can be very disruptive. And I'm not trying to deny people.
Sure.
I'm trying to understand how this doesn't override that capability of a facility to say, we just can't handle right now. No,
Right.
we'd love you to come, but we can't physically handle it. We're stretched.
Appreciate the question. And we try to take those one at a time.
Sorry.
I mean, and I'd love to address that. I mean,
Right.
I think there's a couple things there. First of all, we're giving hospitals, in essence, complete discretion to impose reasonable safety requirements based on their setting. I can imagine a ICU having a different set of
Right.
rules than an outpatient pavilion where folks are sort of resting after a gallbladder surgery and being monitored. There's different ratios of nurse to patient ratios. So there's no way we would want to dictate that, which is why we give them this broad authority to establish what those reasonable safety requirements would be. With respect to the CMS reference you make, we're very careful to make sure that's substantiated here on lines 52 through 53. We give them that broad discretion to make those decisions. What we do, though, is, and I think if you unpack this and think about what we're saying and what we're not saying, is we divided visitors, essential caregivers, which are sort of elevated key visitors, versus the decision maker, the legal decision maker. As we separated them in this bill, what we're saying in that setting, whether it's in an acute care setting or something that's stepped down from that, we're saying 23 hours a day, the hospital can deny access to this key decision maker without any restrictions. In fact, there's no requirement to even admit or deal with this key decision maker for the first 12 hours that someone's admitted. So they come in with a stroke circumstance for 12 hours. They could roll in the door at 2:00 in the afternoon, and there's no need to give them any access until 2 a.m. in the morning. And then only 1 hour over the course of 23 hours in a day. And then, based on the standards, the hospital has sole discretion to decide in terms of infection control. But what we are saying is that to say you can't come in 1 hour, that's where we're taking the soft touch approach. You can keep them away 23 hours a day. You can determine time, manner, place, and all the safety requirements they have to get in. And you can deny them for the first 12 hours you receive a patient. That gives broad discretion. That broad discretion is consistent with our CMS guidelines.
I'm going to say, I think we can have a further discussion because again, it is a broad 1 hour anywhere in that facility, in that hospital.
That doesn't say that. It's the time,
if
the
I read
location
it.
where you can meet the person. All those conditions are absolutely determined by the hospital.
But if my family member is in a COVID ICU unit, are you saying per this law, a hospital would be again, violating this law if they did not allow the representative family or member of that patient,
yes.
the one,
One.
to go and sit in a COVID ICU unit for an hour every day?
That's correct.
Okay.
Under conditions set by the hospital, which could be you have to have a PCR test, within the last 48 hours. You have to wear a whole PPE regimen that's consistent with the employees. Because here's the thing: my son works in a long-term care setting. He's a young man.
Mhm.
He's not in a accredited. He's an employee. He's not a professional in his role. He's working his way through college. He has access. If he were in a hospital setting or a long-term care setting, he goes home. He's around other people. He has friends, has a family. He's tested twice a week. He has to go through and has to follow processes. If another person that's a family member, that's perhaps a 64-year-old retired school teacher with a master's degree, by virtue of them not being a hospital employee, to not do this is to say they can't have access no matter what they do. They could have a negative test. They could follow all the procedures perfectly. But this 22-year-old young man who's working his way through college has access in just because of virtue he's an employee of the hospital system. And the point is, it's a myth to suggest that just because they're an employee, they have a higher status than the person that's the decision maker for this patient.
Mhm.
That's why we have this 1 hour of access.
And I'm gonna, and I appreciate, I think when we talk everywhere, I'm gonna also tell you a personal story. My future daughter-in-law is a physician assistant in an Emory COVID ICU unit for the last year.
Yep.
Now, I will tell you, when she goes home every night, she strips in a separate room, showers before she lives with my son. They do, the discussions of what's going on in those ICU units have gone on.
Mhm.
I would have grave concerns of a situation even in the future that not only have these healthcare professionals been for a year, and I'm not, we can talk broad, for a year been doing their best. They've been living very different lives also. She does not shop. Everything is delivered to their home. That they are then, I don't want to call it forced, but if they would break the law if they say, we just can't handle someone in the bed, sitting next to a bed for an hour a day in that setting. If there's no, I don't want to say exceptions, per this law, the way I interpret it, they have no choice.
Right. But you come from a healthcare background, correct?
Yes, sir.
Okay. If you were not serving in a clinical capacity, but you were a representative of perhaps your parent, what this law says is that you would have access to that parent. Let me say it in the inverse. Without this law, one could say that I'm going to be critical of I'm going to beat up my own son. He's a young guy. My son would have access by virtue of his being an employee of the hospital in a low level role to patients, but you as a healthcare professional, because you're in a representative status, would not. It seems silly. The person's positioning as an employee doesn't necessarily change that there are people who as representatives could follow the rules and do an excellent job of maintaining the kind of protections we need. They shouldn't be disqualified simply because they're not an employee.
Thank you, Mr. Chairman. Representative, we're going to move on. We've got a lot of, I'm going to ask our members to ask one question. We can come back and ask others, but I want to make sure everybody gets their questions in. Representative Bonner, what number are you? 11. Representative Bonner.
Thank you, Mr. Chairman. Thanks, Chairman Setzler. I'll forgo my questions. It's just to simply make my comment. I appreciate you bending over backwards to accommodate all of these different scenarios. And I am one that would be much more broad in the number of hours and the ability. It just seems to me that we ought to, in every case, err on the side of the patient. And we heard testimony in the last meeting from a director of a long-term care facility, how vital it is to them and their employees to have family members and representatives present in those facilities to help with those healthcare decisions. And so I want to commend you on that. I do find it frankly disturbing that I'd see something from the Chamber of Commerce that is against this bill for the sake of business, as they say, rather than the sake of the patients, our family members. We've all heard these stories, and I find it frankly unconscionable that we would in any way find ways to limit access of to our family members in these facilities. So I appreciate you being so diligent in fine tuning this, and look forward to supporting it when we can.
Mr. Chairman, I would just say, I too have concerns about having bent over backwards and contorted ourselves to address these things. I feel like from where I'm not talking about the crazy public. I know there are people out there that might have wild, extreme ideas. I'm not talking about anyone like that, but the well-informed public is in a dramatically different place than where this bill is. The well-informed public would demand much more access than this bill gives. And I think as we've looked through this, even the well-informed public, I trust that organization you referenced has not read this bill. I trust they're talking about a different version of the bill anyway. I don't see how I'm not going to editorialize, Mr. Chairman. I just trust they've not read this bill. They're talking about something we were talking about last week.
Representative Wynn by video.
Thank you, Mr. Chair. Chairman Setzler, I haven't had a chance to go through the substitute version in full detail, and I did hear that you made some substantive changes, incorporated some federal guidelines as well. My question is related to something that Representative Robichaud brought up, which is under the way the bill is currently written, it does not allow for any exceptions whatsoever, including scenarios like if a specialized disease unit was dealing with an outbreak of Ebola or tuberculosis. And from how I understand it is that hospitals do have to make decisions on limiting visitors because it could be a potential danger for, say, the care of other patients or for the patient themselves. So how do we account for things like that?
Well, I appreciate the question. And let me ask a rhetorical question, but for purposes of making a point, I mean, does the decision-making in an acute care setting, even in a circumstance where someone has, you used Ebola as an example. I don't know all the different clinical options to treat that based on where someone is with Ebola as a pandemic issue. But in any acute care setting, does the decision-making on behalf of a patient, is it lessened in severe circumstances, or is it more significant in severe circumstances? The more severe the circumstance, the more significant the decision. The more severe the circumstance, the more likely the decision is a life or death decision, not just one of discomfort or a couple more days in the hospital. So when more do we need to have representatives there than when someone is in dire straits in a hospital and in many cases unable to make fully lucid decisions for themselves? It's specifically for those circumstances, Representative Nguyen, we wrote this bill, because we've got to have we have to have the appropriate decision makers there. And because of your concern you raised, we recognized there's not sufficient interest in this bill, in my belief, that visitors would be there. You know, people that would provide moral support, comfort, and those kind of things. They've been taken completely out of this bill for the reasons you said. But because of how severe those circumstances are, when more do we need to guarantee access to a decision-making representative to be there than these awful circumstances? No, you used Ebola as an example. This doesn't require they be there. This representative can say, you know what? There's a mobile hospital set up by the National Guard and tents, as we've seen, in this, we've got a U.S. Public Health Service has a whole process to build these temporary hospitals. If that kind of thing existed, a representative could say, you know what, because of what's going on in there, because of the severity of this, I'm going to choose to not go see my family member and make the decision. But if they felt like there was a life or death decision that hinged on being able to consult with them and see them, when more would we need them there than those circumstances? That's why we have this bill.
Representative McLeod.
Thank you, Chairman Sessler, and thank you for at least trying to make this bill a bit better. So you referenced several 42 CFR Code of Regulations, great, but that's just, there's nothing in this bill that tells me where exactly this is coming from. And for me as a science major, this is very important as to where things comes from, whether it's CDC, CFR, or the Department of Health. And none of that, there's no reference other than, what is it called? Reasonable safety requirements. But I'm going to go to my question.
Can I address your first, the reference of where it came from? If I could turn your attention to 42 CFR, the 4213, patients' rights, parentheses, hospital. If you look down below, you see subsection, or I'm sorry, you see.
No. I've got it. I
Okay.
know what the CFR is. I'm just saying that it doesn't say in your actual bill itself. So if I'm reading this bill, I can't go back and check what the standards are. I actually work very much. I work in FDA regulated environments.
Sure.
I'm a consultant there, so I'm very familiar with CFR.
But to your point, there is an issue of delegation. When we write state laws, if we say in accordance with this standard, then that standard can change over time. It's a moving target. So as we write state law, we do well to take specific, it's a snapshot in time, and it makes it very clear for the reader that the language we have here, and you see the patient's rights, again, I don't want to belabor the point. The patient or his representative, as allowed by state law, has the right to make informed decisions regarding his patient's rights include being informed. It's a whole list of that lift out of CFR is written in, it's hard coded into our statutes, adopted word for word, which is stronger than a reference, which can change over time and be shifting.
But
sands.
the reference, the actual code, when you reference it, even if it changes and you go to it, usually you go to the most current standard. So if it's 2021 standards, that standard or reference to that code will be updated and you will know what the new standards are.
But that's an issue of delegation. We as a legislature, when we reference things, we're in essence binding in statute something that changes. And there's an issue with doing that. And I know as you go through code, you can say, I'm not saying it's not done in our code. You could find it, no CGA. But to be clear about what we're doing, and I believe to do our homework, we lift the things out we want to reference and we hard code them. And there's a reason for that.
And CMS is the major overshadowing body of regulatory for this particular thing. But let me continue. The way you sound is almost as if viruses take time off. They don't. They are a microscopic organism, and we're the best host for them right now. So as long as we keep giving them a body, they will keep surviving. My question to you is, how do you expect that a nurse or a healthcare worker to enforce legislation like this? And if a visitor comes in and is not wearing a mask and they tell them to wear a mask and they don't want to wear a mask, how are they supposed to handle that? If, how long are they, if they want to stay in 1 hour and they want to stay 4 hours, what happens in that situation? How do we manage this with this legislation?
Yeah, appreciate the question. There's hospitals today, take hospitals as an example, it could be a long-term care facility. They don't have statutory provisions that say specifically with respect to visitors under circumstances. You've got the the flexibility, as we talked about the flexibility, we give them the power in this. And let me read it so I'm not approximating. We give them the power to determine the time, place, manner, conditions. And we clearly give them the power. Hospitals should not be prevented from proposing, again, reasonable safety requirements relating to in-person physical contact with representatives or patients. We give them that power in statute. It's not referencing a regulation. It's not maybe. It's not our general powers. It is specifically granted here. And then we specifically grant them the power to remove people, suspend them, or terminate, which means a permanent removal of access for failure to comply. We
So
give them that
they're
power
gonna
in
get-
statute. What's that?
So they're going to be into the business of policing them.
They're doing it today. Today, our hospitals determine whether somebody is acting appropriately for that setting. The mask issue is an issue today, even without this.
We don't
That-
mandate it in the states, so.
But we give them clear legal authority here to do those things that they don't have today.
Representative Mathis. Oh, hold on.
We still on? There we go. Thank you so much for bringing this. I sitting over here trying to wrap my ears around some of these comments. And, can't get into the legal technical thing with you, but I can get into the moral and ethical thing with you. But before I go to that, I lived through the AIDS epidemic, embalmed many bodies. I'm in the funeral business, picked them up. I've seen other issues. Hadn't seen the Ebola, but I've seen sepsis. I've seen many things that we go through, and those things are serious. But we've lived through those things. Now, COVID is a serious issue. I doubt that none. Listening to the folks that are talking, I don't see them in a bubble. They haven't secluded themselves from the rest of the world. They're out in the world. They shop. They do the hair, the nails. They do all the things that we've normally done. Now, I have seen many deaths in this situation where folks couldn't be with their loved ones. Now, we have a moral obligation to see if we can come up with a remedy so these folks can be with their loved ones. I'm aware of the dangers. I'm aware of the bad apples that may not want to do what these folks are saying. But for the majority of these people, they need to be with their loved one. There are critical decisions that need to be made for these folks that they can't make. And you are right. These hospital workers are stretched thin. I have a daughter-in-law that was on the front line in Tifton, Georgia, in the ICU when the first COVID outbreak hit down there. So I'm well aware of what's going on with that. But I'm well aware of what she thinks of the moral obligation for these poor families that don't have the opportunity to be with their loved ones. Now, these folks live with these folks all the time. Then they got COVID and they went to the hospital. So what's the difference with them being with them at home or being with them in the hospital? Now, I understand that we got to make sure that we help the hospitals and do the protocol. I've been in many hospitals in my area and picked up folks that have died of COVID. I've embalmed several COVID patients, me and my staff. When we go in, we follow protocol. But I do see that there's workers there that are not following the protocol as they should. So I'm not trying to downplay the protocols for the employees of the hospitals or for those of us that go in or the family members. I'm pleading with the hospitals to come up with a policy that works for these families that need to be with their loved ones when they're in these situations, not just COVID, but situations where they have major surgeries, And they are put in ICU one night and they're put into a room day later. They don't have the capacity to make the decisions. Things physically happen. Nurses are stretched thin. They can't, I agree. They can't be everywhere. But if you got that loved one with them, and I've had loved ones in the hospital, even when we didn't have a pandemic. And if we hadn't have been there, in one situation, my little son would have been gone. So I am telling you, I'm not going to get into the details of what's right for this or what's right for that, but I'm telling you, for the moral issue, hospitals need to take on the responsibility along with the public and come up with a workable solution to let these family members be there. Now, I know they can do it. So that's what I'm saying. That's where I stand. And we need to do that for the moral sake of these folks with regard to the severity of what's going on. But we can do it. We have done it, and we will do it again. And this needs to be done. I thank you, Chairman.
Thank you, Representative LaHood.
And Mr. Chairman, to his, we're requiring the hospitals give 1 hour a day to one person. That's all we're requiring them. They have the flexibility to determine everything else.
Representative LaHood.
Thank you, Chairman, and thank you, Chairman Sessler, for the bill and your thorough explanation and for your exhaustive research and work on the bill to get it right. I know you want to get it right. I've got a letter in my hands from the president and CEO of the Georgia Senior Living Association. And this association is a nonprofit association, trade association representing Georgia's senior living industry, representing over 1,600 licensed assisted living and personal care homes in Georgia, serving over 38,000 licensed beds, and it's for assisted living communities and personal care homes. More than 21,000 people work in this industry. And I personally am in a family of 4 generations who have been operators of assisted living and memory care communities. This past year, I've seen lots and lots of devastation because of separation, families being separated. And like my colleague, Representative Mathis said, we can and we will enact policies in this body to make sure this doesn't happen again. There was good reason that the separation needed to happen in the beginning of the pandemic. Now we know more, and I think we none of us had experienced this in our lifetimes, and so moving forward, we must enact policy to make sure that families aren't separated for this length of time again. I'm going to continue with the letter, and I'm going to paraphrase to save time. But the Gina Ryan, the president and CEO of Georgia Senior Living Association, would like to thank you, Chairman Sessler, for bringing the bill and the other sponsors of the bill. She says, without question, the physical and mental health of our senior living residents have been negatively impacted by the unintended consequences of prolonged physical separation and social isolation during the current pandemic. Never again do we want to see assisted living communities and personal care homes unable to allow visits from family members or other trusted individuals for the purpose of providing care, assistance with activities, companionship, emotional and social support to residents in long-term care settings as a result of reduced visitation policies. And she goes on, I just want to emphasize that as a registered nurse and as a provider of long-term care in the non-skilled private pay industry, I recognize fully that there's a difference between the spectrum of care, the continuum of care. I've worked with them all. I coordinated with hospitals quite frequently, skilled nursing providers quite frequently, and in my own business and with others in the assisted living and non-skilled long-term care world. And so there is a difference. There's not a one-size-fits-all. There's not a single solution that will work in every setting. So I commend you for working to make sure each provider group has a workable solution to deliver to families. And I look forward to continuing to work to perfect this bill and to make sure we represent the people of this great state to and ensure their rights to be with their families.
Appreciate the support of the long-term care community in our efforts.
Representative Gamble, I believe, are you number 6? 22. Okay, I'm sorry. I don't know why 6 is anybody else?
That's okay.
I was trying to figure that out. Okay, Representative Gamble.
All right. Thank you, Mr. Chairman. To my friend and my neighbor, Chairman Setzler, thank you for this bill. And I have some questions I do want to ask you, and I appreciate you clarifying the Ebola situation. I think that that's something near to my heart with Phoenix Air there in Cartersville, Georgia. The transporter of these patients, those units are parked at the Cartersville Airport 24/7, ready to be deployed if they need to be. My question is related to inmate areas and whether or not that would be exempt from this bill, or how is that addressed in this particular topic?
When you say inmate areas, you mean like a forensic unit where you've got someone that's been convicted of a crime, they're in the hospital?
Correct.
It's my intention that this law enforcement provision we've got on line 72 through 74 can provide for that.
Okay.
If we've done that ineffectively, I'm open to feedback of how we can hit the center of the bullseye on that if we've missed it.
Okay. Thank you.
Because again, I think there's certainly a risk to this idea of these exemptions just ballooning out of control.
Mm-hmm.
But I think the criminal justice interest is important. I think having said that, though, if you've got somebody in a criminal justice circumstance, we certainly wouldn't want access to counsel, for legal counsel to come in to say, hey, they may be in the hospital. They may be a suspect. The probable cause may have been demonstrated, so they may be detained by law enforcement. But just because there's an emergency pandemic, they shouldn't not have access to legal counsel, right?
Mm-hmm.
So, and I don't think we contemplate that, right? So when you think about this idea of representative for non-suspects, this representative is tantamount to legal counsel, right? So those things are really almost inseparable, or should at least be seen in parallel if they're not. So study the language for me if we need to tweak this. That's where we're making the presentation.
Yep, I know you will, and I
open to it.
appreciate your commitment to
Yes,
that.
sir.
Thank you.
Yes, sir.
Thank you, Representative Gamble. Representative Byrd.
Yes, thank you very much. Thank you, Chairman Setzler, for this bill. I do hope that we can find some solutions that is befitting to all of us. But I want to add to Representative Mathis there. I'm sure there's been many times that there have been other diseases that have been in hospitals and facilities, and we've never been in a lockdown situation where people cannot visit their families. One that comes to mind would have been tuberculosis. The only time I think that when they had tuberculosis, the only person that really wore the mask was the patient themselves, and I don't remember anybody being locked out to see anyone. So just getting my head around of how we all of a sudden, at this day and time, that we are shutting the doors to people of loved ones that care about their loved ones in a hospital situation, facility, doesn't matter. So it's very sad to think that we are at this point in our lifetime that we have to make a decision through legislation so that a person can actually go and visit their loved one. My question right now, though, is if with your bill, is it my understanding that the facilities would have the ability to set standards for each one of these persons to come in and visit for that 1 hour? Does that mean that they could stop anyone from coming in to do their 1 hour visit if they so felt that when they wrote their own standards?
Well, it's a great question. And again, to your earlier point, I really struggle with having conceded and given away so much family and representatives prerogative as I have here.
I know.
I struggle with the bill I'm presenting to the committee today. Is 1 hour a day for a decision-making representative adequate? I struggle with that. It's my personal opinion that's inadequate. But to suggest that it should be 0 is just flatly unacceptable. And that's so as we've prostrated ourselves to try to get to an agreement on this with the healthcare community, I think we've landed where maybe the last place we can go. Now, to your question about those provisions, we've given to answer your question, this bill gives the healthcare provider broad discretion. I think what could clearly be characterized as broad discretion to determine time, place, manner, and conditions. They're held to a reasonableness standard. So if I'm making this up, if we're thinking about what that could mean, I think being in some kind of negative pressure, suit that's got, I don't think we're talking about that. When you see people in a bioscience 3 or 4 laboratory at CDC and some of the conditions they're in, we're not talking about that, right? I think that would not be reasonable. But we do give the hospital or long-term care provider the flexibility to say, hey, you got to do more. You have to have more PPE if you go into ICU, or if it's a burn unit where infection's a bigger issue. We do give them the power, the sole power to make that determination within the standard of reasonableness. So that's, again, broad power we're giving them to make those determinations. But yes, we're not trying to prescribe any more than that here. So
And just to follow up, so to the best of my knowledge, when you go to visit someone in a hospital, you have people that come in and clean your room, they clean your trash can, they bring in food, they have your healthcare workers coming in and out of your room. So are they all following a protocol? I mean, are they being stopped at the door? Let me get your temperature, go get your nose swabbed. I mean, all of these things that you're now talking about, an individual that wants to go see their loved ones are going to have to do all of that sort of stuff.
I think it's likely to expect that the requirement for these representatives would be consistent with employees. But again, as we talked about earlier, does that employee create more of a threat to the one legal representative who's a decision maker? I don't think I think as long as standards are enforced, I don't think there's more risk there. So I think, yes, you're spot on with that.
Representative Bazemore.
Thank you, Mr. Chair. Thank you, Representative, for this bill. And I'm sure, as we discussed last time, we had this discussion that everybody is concerned for every family member. I could not imagine if I had a family member and I could not get to that family member. However, you would agree that we are still in a pandemic, correct?
Yeah.
And that the governor has laid down certain restrictions.
Sure.
So if those restrictions are adequate, then we have restrictions also in the hospitals and the long-term facilities. And I want to go back just for a minute to a comment you made about your son going in and out because he's an employee. Well, we're all employees.
Mm-hmm.
We come to the Capitol every day, not by choice.
Right.
We were hired by our constituents to come here and represent them.
Mm-hmm.
A lot of us are scared because a lot of us have underlying conditions. And so there have been situations where people have gotten sick, but we come and go in all of the different buildings because we get tested, but we have restricted that same access to other people. So we're not more important than anyone else. So if hospitals and long-term facilities, because now you're dealing with sick people that are sick, and now you're opening up that facility to different ones to come in and out. And I don't know if you've heard recently that more variances have been found. Just recently, they talked about different variances. So, and one started right here in Georgia.
Mm-hmm.
So we don't know yet what this COVID-19 really looks like or how it's going to act going forward, despite the fact that we have a vaccine.
And to your point, I mean, I think I think people who spend time here, you can look around if you're in the room. There's a lot of folks at our state capitol now that are not elected representatives because they're essential to the running and the operation of the legislature and the governor's office.
Right.
Likewise, a specified decision maker, representative decision maker, is essential to the care of the patient. And I think what we're talking about here is a premise. That the premise that they're just nice to haves is a false premise. The premise that we recognize in this bill is they're essential to care. The decision maker for and with the patient's essential to care, just as many of the people of this Capitol are essential to the legislative session, even if they're not elected representatives. So that's the essence of this bill. It's not nice to haves. They're essential to the delivery of healthcare. No.
I mean, they're elected people. Not elected, they're hired also. And then you have those that have interest. So they have to get tested also. So they are tested just like we are tested.
Correct.
We had a situation where someone did not want to get tested and was not allowed in. So they're not allowed in the building.
Right.
But we're going to allow people to go into the hospitals and long-term facilities. You are
If
now.
they follow the conditions specified by the hospital, which I think would not be inconsistent with what they require of their employees.
So the responsibility, from what I'm hearing, is solely on those facilities to do everything when we know that hospitals have been closing at record numbers because of financial
I think if you ask
loss.
Yes, ma'am. I think if you ask them, would they rather us to define those conditions? Or would we rather they be allowed to define the conditions? I think they would rather have that authority themselves than for us to define that for them. And I don't have the conceit that I can just put that in the bill. I trust them to make those decisions.
Okay, we're going to keep moving. We want to make sure we're an hour in. Representative Cannon by video.
Thank
For a
you
question.
very much. Thank you for working on this bill. I, as a labor doula, have been in the hospitals helping people give birth during COVID-19 and would want to be very clear that the hospitals deserve time to figure out these policies to account for dealing with additional outbreaks that involve additional protocol, including issues of attack or harm, so that there will be additional implications for the healthcare they can provide. I did want to really generously say, do workers have capacity at this time for additional scheduling and temperature checks, COVID protocols, with 2 to 3 more times people? I do think this is something that we can work on, but as you've stated, the rushed or hurried nature, there needs to be more time. To the specific issue I have with the legislation at this time, as was brought up by another member, line 71 through 74, as it relates to probable cause for being able to be removed from a property or have access. And I'm wondering the costs of the PPE to the facilities for these additional representatives or essential caregivers. Thank you.
Thank you, Representative Cannon. I'll address the question of the probable cause standard. Again, as you think about this, we don't want to create a difficult burden on healthcare facilities to run efficiently and provide safety. So if you think about this, what's the appropriate standard? If conditions exist and information exists that allows someone to be arrested and removed involuntarily in any setting, that seems to be the appropriate standard in this hospital setting. There's a standard, beyond reasonable suspicion that rises to what we would call probable cause. That's the standard by which any person in any circumstance can be arrested by law enforcement. We simply tap into that same standard for removal. It seems consistent. And with respect to PPE, we're not mandating in any way, nor is it contemplated that the hospitals are going to be responsible to provide PPE to people. Once again, the idea of essential caregivers, family members coming in or representatives, that's a cost that could be borne by the representative. If perhaps healthcare insurance in one case decided to pick that up, we're not prohibiting that from happening either. But we're not talking about $10,000 of equipment either. We're talking about, the conditions in which someone could have access to visit someone and help make a decision. So we're not burdening healthcare providers with that anyway in this bill.
Okay, Representative McDonald, do you have a question? What number are you, Representative? Is that 13? 12? Okay.
Thank you, Mr. Chairman. Of course, history of me, I've 27-year firefighter, coroner of Forsyth County, 16 years. Been in the same business as Mr. Mathis. Heard the stories all since last February, January, February of not being able to see a loved one. The embarrassment part to me is I didn't bring this bill before you did, because I've experienced it so many times throughout this past year. And I sat here last week and listened to the testimony of all the different people that came before us, and they all had a different story and their experience. But the one that really got me was the one with a skateboard, the young lady that was killed and that was on the skateboard. I think it's from Mr. Mathis' community. But it wasn't until Monday that I'm sitting at the funeral, I'm about to wait on a family. I get a call around noonish that my second best friend in the world had been involved in a car wreck in Greenville, South Carolina. First response, get in a car. Fortunately, going towards I-20 was my house. Grab my Capital bag that have all my clothes in it. Didn't know what was in it. Grab my son, and we take off driving in the rain. And we get to Greenville trying to find out what's going on. Finally, we know they're okay, but they were T-boned, my dad and my mother-in-law, and sitting in a parking deck for 5.5 hours, not being able to see them. And I got it. I didn't need to be in that hospital, but that was just for 5.5 hours. I couldn't imagine what these families are going through day after day after day, not being able to see their loved one and be a part of that decision making, because I'm an only child, didn't know what was going on in that hospital. So after hearing that Thursday and experiencing what I did Monday, this is a heartstring on me and all the stories I've heard over the past year. So I just want to thank you so much for bringing this to us.
Thank you, Representative. Okay. It's a little bit out of the ordinary. This is worrisome news to me. We have Representative Allen. Let me make sure I understand. We're going to read a comment from Representative Allen, who's a member of this committee, who cannot be here. I want to make sure I understand why, because his wife is in surgery. Okay. All right, I'm going to read this to all our members, if you can hear me. I'm not in a position to speak, but would like someone to read this if possible. I thank Chairman Setzler for his commitment to this issue, and we all agree that this is an issue worthy of our debate. I want to make sure that we do not lose sight that our hospitals and healthcare workers have done an amazing job dealing with this pandemic. The choices they have made are hard, and I'm sure, 100% sure, they did not delight in being able to keep a family member away from a family member in distress. I spent 6 days in the hospital 3 months ago, and it was hard not to see my family. But I also know the hospital's first motive is do no harm, and that means keeping everyone safe. I would also argue that the situation has drastically improved, as noted by my being able to be here with my wife today. By codifying hospital visitation, we are being restrictive and not allowing healthcare professionals to do what they are far more qualified to do. Something needs to be done, but I'm just not sure we have the best approach and solution before us. Okay, those are words from one of our members. All right, here's the posture we're in. Is there any other members who wish to speak to this measure? Has everyone fully asked their questions? Okay, All right. I'm going to ask you to be very brief. A very brief question, Representative Bazemore.
Representative Sessler, one more question. If you have individuals coming into a room, because we know that in hospitals and different facilities, there's more than one patient to a room. What do you do with the other patients? Do they all just congregate in the same area?
Well, to your question, that's not universally the case. I know some hospitals have cohorting where people are together. Other circumstances, they're separated. There's other circumstances within a setting that's maybe not quite such acute care that there may be a room that could be designated for this kind of contact. In a long-term care setting, I know there's arrangements where there's a day room or an entry room where people are brought down because they don't want folks back in the, even for visitation, sort of back in the rooms and that kind of thing. Because the settings are as diverse almost as the facilities, we're not looking to define that, which is why we give the broad discretion to the time, manner, place, and conditions. Flexibility we give the healthcare provider. I'm not trying to write a bill that says, well, there's two people in the room. What does that mean? We can't solve that problem, which is why we give the authority to the healthcare provider to decide that.
Thank you, Chairman. Representative McLeod, again, very brief, please.
Yes, thank you. Just for the record, I do my own hair and I don't do my nails.
Okay.
To determine the
question.
So I wanted to ask, why does this bill take long-term care facilities and treat them the same as nursing homes and assisted living facilities as the same as hospitals?
Well, there's a skilled nursing setting has differences, to be sure, as we all recognize, the ratios and just a whole host of things. But a nursing home is a setting where someone is living and residing. I mean, there's services that are provided there, but it's not the acute care setting the hospital is, where people are there to have their conditions addressed and then moved on to another setting. So it's an acute care setting with various levels of intensity, and then really a living arrangement. And it's a nursing home is a living setting. It might require more supervision, but it's still a long-term care setting. It does for that reason.
All right. So here's back to where the posture we're in. All right. So that is all the testimony we're going to take today. Chairman, we appreciate you being here. Here's what we're going to do. The chair has made a decision. So we had 3 hours of testimony last week. We've had plenty of vigorous testimony today and debate amongst our members alone. And so, as I mentioned earlier, as I was sitting here listening, I want y'all to recognize this. First of all, I believe what I said earlier was true. This could well be one of the most important measures we deal with this session. I believe it is that important to the people that we represent. I know it's important to the people I represent because I'm hearing from them. And we've all heard of the heartache and the terrible stories have been powerful to all of us, to every one of us. We also know this. We know that our hospitals are heroes. We know that our skilled nursing facilities are heroes, our assisted living facilities. They have charged in to take care of people while everybody else was running to hide under the table. They've been taking care of folks. So here's what I believe philosophically. It's my duty to make sure, first of all, that every member here is heard, that everybody that wants to speak is heard, and then that we thoroughly educate ourselves. So here's what I want us to do. I'm not going to accept a motion to take a vote on this bill today, but here's what I will make a promise to you, to every one of you. We will vote on this bill next Wednesday in room 341 at 2:00 p.m. That is our next committee meeting. On that day, we needed more debate. I sit here and listen, and we needed this. We need this. We are here to perfect bills, not just to sling them out there. We will perfect this, and it may be perfected, Mr. Chairman, but we will continue to work together to do the will of the people. And I believe that given us till next Wednesday at 2:00, by that time, we're going to have a bill. It's going to be presented by the chairman. And then we're going to expect everyone here to be prepared to vote on that measure, because it is crucial that we solve this problem for the people. Thanks to all of you for being here, and we will see you on Wednesday at 2 p.m. in room 341. Thank you. Thank you, Mr. Chairman.